Okay, good day, everyone. This is Dr. Stephen Beck. We are Bluetree. I'm here with Julia Earley as well. We're going to present on telehealth strategy and solutions today through this webinar. Thank everybody for joining. We're going to go through some basic logistics before we get started with regards to the webinar. So everyone is muted. That's there by default. If you haven't used GoToWebinar before, it's pretty simple to either use the computer audio or your phone call. You should already be connecting and seeing my screen and hearing my voice. If not, we're going to be in trouble. So you are all muted, but that doesn't mean you don't have the opportunity to contribute and ask questions as well. So within your control panel, there is a section that allows you to post questions. We are going to allow plenty of time at the end of the presentation for questions, and we really encourage you to do so. There is the little grab tab, as it's called, or the orange arrow at the upper left-hand corner that can collapse your panel. So if you don't see the question box, you just click on that little orange arrow and that opens things back up and will allow you access. So as I mentioned, feel free to post questions as we go. We'll collect those and run through the questions at the end of the session. And I just wanted to mention, we also have some poll questions along the way, just to get a sense of what's going on with your organization. And I think that'll help direct some of the conversation that we hope to have today. So you'll see those poll questions appear on your screen as well. So let's go ahead and get started. And we're actually going to start with a poll question. So we'll present that and we'll give a pause for a little bit of an answer. Okay, just a couple more seconds for folks to answer. And you can see our results that the majority of you on the line are in implementation currently. Some are just starting, and none today that really haven't thought about this very much. So that's great to hear. We're very excited to be able to fill in some details and fill in some of the gaps, especially for those of you that are along the way. As we start today, I am going to start with some basics. Hopefully that'll help everyone. But in addition, just think about some of the other topics as we go through that might spur some ideas for those of you that are already in implementation phase. So just starting with some basics about why we need telehealth. A lot of times when I talk with health systems, the answer seems to be, well, because people want it. And I like to think a little bit different from that. We need telehealth for many other reasons. First and foremost, we have a very large population that's aging, and it's creating some care gaps. So we're having a tremendous number of provider shortages these days, and that's only predicted to get worse. There is a high percentage of providers that are at or near retirement age, and as they retire, the replacement providers aren't going to meet needs. And lastly, on this slide, the care between visits is more and more important. So chronic care is much more important as we age, and there's a heavier focus on quality outcomes and quality metrics, not only by the government, but insurers as well. As a provider, I can tell you, it's an important part of managing all of my patients' health as well, making sure that they're getting what they need in between visits. So the good news is we can meet all of these challenges with telehealth. First and foremost, by increasing access to care, but also increasing the quality of care that we can deliver. Importantly, there are studies that can show that we can reduce cost of care by appropriate use of telehealth. And as we start to talk about how the vendors are in this space and others for visits that are very inexpensive, we as a health system must also decide, is this something that is actually increasing care? In other words, are patients seeking care outside of our health system? And that's one of the reasons why most health systems are really devoting time into telehealth. So let's talk about the ideal state. So I always like to think of telehealth from the patient's point of view or the consumer, and we'd like to think that it's as easy as possible. So basically you have a smart device, might have a desktop computer, perhaps a tablet, and we're engaging with a provider through the device. And that can be any of a number of ways, but think now about what I don't have to do. I no longer have to get childcare for my kids who might be at home. I don't have to leave my place of work. I don't have to wait in line. I don't have to get exposed to potential conditions in a clinic or an urgent care. All of those things really add up to a perfect ideal state for the care delivery setting. So the challenges that many of you who have started might already experience is that I like to say it's a three-legged stool with regards to telehealth. And first and foremost being technology. You have to start with that. The other legs of the stool are going to include access and reimbursement. But starting with technology, many would argue that this is actually the easiest part to implement. It, of course, is the most costly. So coming up with a solution that can meet your challenges can sometimes be the easiest thing to do. So working with a vendor or working with your EHR to enable this two-way access with patients. But I would like to challenge you with some other questions. First and foremost, what happens when a patient has an issue with their device, whether it be at home or they're on the road? Do you have a help desk? Is there some other functionality that lets them solve their problem with their device? Are there any requirements on the device? In other words, do you have to have the latest and greatest? And what do you do for people that don't have a device? They might have a flip phone. So we have to think about those things as well. Additionally, can your current help desk solve the problems, whether that be in a hospital or a practice? And then last but not least, does your community have high-speed communication that would enable this, assuming that we've got all those other pieces? So it's just some things to think about with regards to technology, and it's perhaps some of the issues that a few of you have already experienced. So I'd like to talk about the second leg of the stool as access. First of all, as a internist, I like to think that patients have a healthy addiction to their primary care provider. They really want to see the provider that delivers the majority of their care. These days, that really represents a care team. But in my view, those members of the care team know them the best, a lot of times have personal relationships, of course, have full access to their records. And it's that trust that allows them to get care. The problem being now is that those providers or that care team might not have the access to provide to a patient. So we have to think about access relative to providers, but we also have to think about those social needs with regards to access that I already spoke about, making it difficult perhaps for some to have community access issues where they don't have the transportation. So are there ways that we can overcome access, make it easier for patients to find appointment slots, virtual appointment slots perhaps? Uh, and then are there other providers outside of the care team that we have access issues with? Many communities have mental health problems and have a very large shortage of mental health providers. So can we use this tool to access those providers as well? And of course, the answer is yes. Last but not least, of course, is reimbursement. And when I talk to health systems, a lot of times it's reimbursement that tends to hold them back from even starting. The good news is reimbursement models are changing. CMS is changing the way that virtual care is paid for. Currently, most of you know that a brick and mortar form of telehealth is oftentimes reimbursed with regards to mental health. So for example, you could use telehealth in a clinical setting, referring to a provider that's in another clinical setting, and complete telehealth that's fully reimbursable. Again, is that the easiest thing to do? Maybe not, but those reimbursement models are evolving now. The other thing is that patients we know are willing to pay for this care when it's virtual. Again, we talked about those social costs that are involved when it comes to transportation and daycare and even being away from work. And patients are willing to cover the costs of that. And we know that because of the large access to current systems that you might find on your phone that are associated with your Walgreens app or associated with your Samsung Health app. Carriers like American Well that have made freely available $49 visits. And patients are taking advantage of these and they're willing to pay out of pocket, knowing that it's more efficient for them to do so than some of their social issues. So with that in mind, I just pulled a few headlines that have happened in the past few weeks to think about. And really, as a health system, each of you need to think about who your competition really is. So this headline talked about the relationship of Doctor on Demand and Humana. And as I mentioned, many health systems, health insurance plans have been doing this independently of practices. So again, sometimes there's a collaborative work between the third party, in this case, Doctor on Demand, and the insurer, leaving the provider out completely. So that's a little scary, but it does happen. So in your individual market, it's one thing that you should certainly look into. There's other opportunities where all three of them are working together, collaboration between the insurer, the provider, and the patient, and the employer as well. So things to think about. Technology is changing rapidly as we know as well, and there's new technology partnership relationships. I found this one to be quite interesting, where Best Buy was actually taking a partnership with TytoCare. And the point being here is non-traditional organizations like Best Buy are now investing in some of these digital health strategies and digital health spaces. So again, this can be a partner, it can also be competition as well. And then the last one that's important to mention is large organizations beyond CVS and Walgreens who've had Minute Clinics and have worked on this type of virtual care include large employers. Walmart's a huge employer across our country, and for their self-insured now, they've dropped their virtual visit costs from $40, which is cheaper than the national average I mentioned, to $4. So not unlike what you might have when you walk into a drugstore and get your prescription filled there. Organizations have been dropping costs to gain it in other places. Of course, if it's your own employees, you want to give them an excellent experience as well. So think about these things as you're exploring your own markets and really understanding what your current setting is for patients. Are you making it easy for patients to get care? And is virtual care helping you, or is it standing in the way of the care that you might deliver? So that's the basic intro. Hopefully that's spurred a little bit of thought and hopefully some conversation as well. As I mentioned, along the way, feel free to post questions as we go, things that might come up. We'll review those at the Q&A session at the very end of this presentation. So we'll pause for another polling question as we start to transition about next steps. So read through this and give us a sense about what's your major obstacle to telehealth at your health system. Okay, we're going to go ahead and close the poll. And as you can see, a majority of you are talking about reimbursement being a major obstacle, and then technology being a piece as well. Glad to see it's not an organizational goal is not one of the answers. So we're excited about that, and will help us as we continue the discussion. So I'm going to turn over to Julia, and we'll continue our conversation with how we can help deliver.
Thank you, Dr. Beck, for helping us understanding why telehealth is so important. My name is Julia Earley, and I'd like to discuss with you today about telehealth delivery, highlighting some of your concerns that were addressed in the poll, as well as highlighting some items from MyChart video visits. MyChart video visits allow for providers to offer patient visits using a video connection instead of face-to-face. In many respects, it's the same as any other patient encounter within Epic. They're scheduled, performed, documented, and billed using Epic Hyperspace. But the concepts that we're going to talk about today simply apply to the world outside of Epic as well. Knowing that many of you have an Epic focus, we wanted to kind of just highlight some of those informations. So now that we know the why, let's talk about delivery, which everyone's favorite piece, I feel like, is video integration. Specifically for the MyChart video visits, the video component will be conducted through Haiku and Cantu, and then all of other documentation happens within Epic itself. Since Epic and other vendors aren't providing you with that integration piece, this is the step in everyone's favorite step, which is vendor selection. When looking for a vendor, we kind of recommend the one that it's like dating. It's the one that gives you the good butterflies, and therefore is someone that's easy to work with. And the amount of build that is required. We have worked with some vendors where all you have to do is set up connectors in each environment, and that's it. So you've kind of got an easy baseline. Others might offer more technology, but require an intensive team to help then support it. Video integration and who you decide to work with will be dependent on your scope, and a streamlined approach to really define those guardrails is highly encouraged. So we've seen success in only using a video smartphone mobile app, Haiku and Cantu, and not going into the PC and workstation world. By doing this, you are reducing complexity, and in turn, you're able to provide better support. What we call this, and what you're familiar with, is device strategy management. So how is this going to work, and who is going to bring it? Are providers going to be bringing their own devices to the table, or will your organization be supplying it? If you do choose to do PC and workstation setup, it makes video integration more complicated, but it is still manageable. The more complex setup that you have, the more likely you are going to engage with compliance. When we speak of compliance engagement, this is the true guardrails of the program we've been talking about earlier and throughout our afternoon together. This team is responsible for generating the forms and the waivers specific to telehealth, and if done effectively and efficiently, your ground zero documents. So if your company's organization is called Bluetree, can then be used for your affiliates as you look to expand into that space. What we mean by that is your ground zero documents cover everything, and then simply moving forward, it's just a control place for your Bluetree organization name to your Bluetree affiliate organization name, as an example. for the major system build and things to consider with compliance is how your e-check-in documents are going to be handled. Some will require, a consent with every visit. And then how will that be signed? So can it be signed in the office? Are we only accepting patients that are existing patients within our health system? Or are we going to allow for mobile signature via smartphone? These kind of pillars build nicely into reimbursement, which we hear loud and clear is a struggle for many organizations today. The key thing to remember with reimbursement is an ever evolving in the telehealth space. And therefore, we have a few options we want to talk about when tackling on how to get paid. The model for reimbursement may drive other aspects of telehealth deployment, including when and to whom and how your visits are offered. We recommend starting your telehealth program in a pilot to learn more about your payers and patient populations in order to maximize your profit in the long run. From experience, we have worked with customers who have reached out to several payers to try and determine if they are reimbursing video visits, and we received very little concrete feedback. At the start of this year, many of you are aware that Medicare has started to reimburse for MyChart video visits, but that also is going to require build and support in setting the claim to Medicare. A few strategies that we are familiar with and would recommend is one that we're all familiar with, which is bill the insurance and patient is then responsible. This is generating a claim for a service, and then if the claim is denied or partially reimbursed, the patient is billed an uncovered component of the self-pay cost. This will require, if depending on your build structure, your affiliates may need to intervene manually to adjust the cost before the patient is billing, but is certainly an option. Another option, which Dr. Beck has alluded to, is offering the service for free. Since video visits tend to replace non-reimbursable follow-up care, offering free as a baseline is a good way to encourage people to join your platform so that they become comfortable, and then that platform can, of course, change in the future. And then finally, commercialization is an easy approach, which is where you just are going to charge a flat fee for X pay itself dollars, so say $75 for the convenience of the telehealth visit. And a pilot approach, we recommend generating a claim to pay for your to your payer for your services, and any uncovered costs will then be written off. There are, build considerations within Epic if you are an Epic client to consider for generating that telemedicine business. But again, it helps you understand your specific environment and what will get paid and what will not. The key takeaway, though, from reimbursement strategy is to design your program to identify who will reimburse and then make it scalable, which is why we highly recommend doing a pilot phase. In a post-pilot world, if a payer doesn't pay, then the patients are responsible. And then, of course, the path of least resistance is that flat fee for service. If we could move forward in talking about how else we know our delivery. We've talked about the big things so far, but who are our patients? So simply put, targeting patients and visit types is what is your patient population and why would they benefit from this service? Oftentimes, it's easy to get caught up in new technology and buzzwords, but it's very important to remember, why are your patients benefiting from this service? Is it because of geographical constraints? Is it a time constraint and they need visits before 8 a.m.? But remembering that why and carrying it throughout not only your design, implementation, and then post will help guide you and keep you focused on what is a priority to your organization. Your strategy for telehealth will drive when and how the appointments are scheduled, and target visit types to consider are things that are otherwise not reimbursable. So if you need to touch the patient, probably not a good idea to move forward with that type of visit type. Your strategy may evolve as you gain experience and comfort with the platform. So starting with the basics is always a good idea to learn, because it's a new landscape for everyone. That moves into our governance. Similar to having a strong compliance team, having an even stronger governance team in place is a major key to success in this process. This group of people is responsible for making the decisions and answering all the little questions that come up along the way. Typically, we see a telehealth supervisor, manager, IT, and compliance are a few roles at that table. What they're governing is all those little functional dependencies. So the little tentacles that help make a program for a success. So how are you signing up e-signing of documents going to be set up? Is a telehealth encounter there for your e-visit workflow? How will your financial waiver be built into the workflow? If you're going to deploy functionality, you need to consider these type of questions. And another one, which you're all familiar with, is how are you going to collect the money? So if it's a telehealth program within your own organization, can you use the credit card tools and already in place? If it's with an affiliate where you might not have that same structure in place, are you going to be mailing post-visit to collect? In speaking about affiliates, it's kind of important to think about what does that relationship look like with your organization and the standard offering and what's being offered to your affiliates. One way we have seen to encourage affiliates to not only join your instance of Epic, but to roll out the telehealth functionality, which then increases your referral network back to your parent organization, is to subsidize the video licensing and make it available at no additional cost as long as they stay within the permitted licensing per visit. Finally, when we consider what we need to involve in our telehealth strategy, we can look at operationalization. This is simply bundling it all together. It is everything that goes into every touch point of the patient experience. So starting with what space will the video visit be conducted in? As with any visit, it is best to have a dedicated, private, well-lit space. Other things to consider are, does the MA room the patient and complete virtual vitals, or does the provider room and greet the patient and then begin into documenting the visit, and what happens to no-shows is always a good thing to think about, because just like with the normal clinic, that will happen as well. A big thing to think about when we look at the spectrum of the experience is how are staff and patients going to be trained on the workflow, and what does that communication look like? This is important because it's new for everyone, so the normal assumptions don't come into play. Staff versus patients are two very different audiences to consider when formulating your communication strategy. The good news is once you go live with telehealth and it becomes part of your platform, it's then, your new child. It's part of your workflow and a part of your standard operating procedures. This is a lot of information, and some of it you may feel like your head is spinning, and that is totally normal. So let's take a breath and talk about how we put this all together and what we're calling our proposed telehealth strategy. So first thing that, from a high level, if you notice, we're going to start this process, and this process doesn't end. It just starts again. Knowing this about telehealth will make you a success, and it isn't something that can just be checked off the box like, yeah, we have that and moved on from. So congratulations on your new partner known as telehealth. A lot of decisions when it comes to video integration or target population will need to be determined in developing that standard offering. These considerations are the variables we talked about on the previous slides about how do we get into the selection process, what will your reimbursement model look like, what specialties is this limited to, and what type of visit types is this limited to. We recommend using a pre-implementation questionnaire worksheet to define things like consents and waivers, reimbursement models, and devices. One thing to note is, depending on the specialty and your target population, are there specific review of system questionnaires required to offer to patients in order for this to make a success? Through the standing offering process, you'll be easily able to slide into your pilot. In the pilot phase, you will already start to refine your process as claims come back and feedback is received from the community. The importance of the pilot will dictate your future. And what we really recommend is evaluating the pilot results so you are able to refine your standard offering into help integrate telehealth into your platform. Refining the standard offering is where the reimbursement changes come into play, as you will now have the firsthand experience of things that are working and not working. From there, your broad deployment of the standard offering will then occur in this continuum of strategy. This is a great time of growth for your organization, and you start to see the benefits of the fruit for labor that you put forward back in developing your standard offering and in your pilot. From there, telehealth is now a part of your platform, requiring continued program support, and it's always starting again. With every upgrade, with every reimbursement change, with every governmental election, telehealth will more than likely be impacted. We can't stress enough that continued program support cannot be forgotten and is part of your new telehealth strategy and platform for your organization. With that, I'd like to pause and thank everyone for joining today. We've enjoyed presenting and hope you have found this valuable, and would like to open it up to questions that you may be having. As Dr. Beck had alluded to in the beginning of the presentation and showed you those PowerPoint slides, you can open up your GoToMeeting, and there's a space for questions. So we will pause a second for that.
So as questions come in, I see one that's come up already, and it's probably a very common theme, which is what's the ROI within the strategy, and how long can you assure ROI relative to your telehealth program? And the answer to that can be complicated. Of course, it depends on what your offering is. But the advice that I typically give health systems as they start is to recall that as you work on an integrated project like this, of course, a pilot's going to be a very small test of change. But as you start to grow that pilot into a successful implementation, keep in mind that the only way that patients know about the offering is through a very strategic communication plan. And so how we communicate with our patients about the offering and its availability is critically important, and sometimes gets missed. Does this become a billboard that we need to put up? Of course, we can use direct outreach through MyChart. Is it a new section that can be highlighted? Is it a pop-up that can appear on the website to your health system? Many different approaches to it. All of those will drive how many patients you can actually drive into usage of your deployed telehealth offering. And then, of course, that will determine what the ROI is. Keep in mind that when it comes to video visits versus face-to-face visits, they typically take longer. So if I'm seeing a patient for a simple upper respiratory infection in my clinical practice, I can do that very, very quickly. If I don't have the same tools available, and again, some vendors do allow tools under some certain circumstances, I have to ask a lot more questions. It really takes a bit longer to do the same bit of work. So keep that in mind as well as you're looking at ROI. In the beginning, it will take longer. Be sure you plan out your communication plan, and then have a strategy for what you want your ramp up to be. The last comment I'm going to make there is I was investigating a third-party vendor a couple of years ago that offered me a card for free service, a free video visit. And I still have the card in my wallet. The problem is I just haven't been sick. And so I've been blessed by not being sick, but also haven't used the service. So think about, again, the type of service that you're offering, and that it may be dependent on people seeking active care. And if you have a very healthy population, that can sometimes make the difference.
Great. We received another question. How do you know which reimbursement strategy to start with? This is a great question. Research is the best way to determine a recommendation on which reimbursements to start with. This includes researching your payer mix, your governing reimbursement rules in your area that are applicable, and talking with other organizations in your area. The beauty is you are not alone in this landscape, and no one has it completely figured out because it is always changing. This will be an iterative process, and if you not only know that now, but we can kind of accept that and make peace with it, make it your friend, this won't cause heartache down the line. As we stated earlier, we recommend starting with going with the payers and seeing what's reimbursed and not reimbursed, and then reassessing after that pilot phase.
I might also add to that, Julia, is that because states vary so much, I think you should look at what's in your state laws. So there's some great websites that are available that allow you to look up what is in the works with regards to your particular state, with regards to telehealth offerings and or restrictions. Those are important as you look at whether or not, for example, your health system, which might cross state lines, needs to follow the rules of 2 states versus 1, and whether providers from 1 state can deliver care in the other state. So those are other areas to be sure that you research and continue to look at as the rules continue to change, and there's so much excitement in this area.
Yes. And another question that we received is, how long does it take to implement? This is a great question that we receive all the time, and the response is you probably won't like, but it all depends. So for example, if you're rolling out to one group, one visit type who already has a video integration in place, that could be less than 3 months. If you don't have a video vendor selected, you're unsure who your target patient is and how reimbursement works, then that can take, a solid 6 months or if not more time. If you'd like to further discuss the needs of your organizations, please reach out to myself or Dr. Beck, and we can help definitely give some guidelines. And we still have some time and see people are on the line if there are any other questions or that people would like to discuss, or challenges that people are facing. Oftentimes everyone is facing similar challenges, so we can open it up for discussion with the group as well.
I see another question that's come through, which is, with regards to pilots, is there any guidance with regards to specialty versus primary care? Again, I think as you're analyzing the potential for a project, there are opportunities in both spaces. So I'll give you a couple of examples very quickly. So of course, urgent type visits that might be considered primary care, or sick visits is one alternative that a lot of health systems like to start with because it's fairly straightforward. But you might have the opportunity for a headache specialist, for example, that's treating people with follow-up visits for migraines. And typically there's very little exam that needs to take place for those types of visits. So it's an opportunity that might be niche within your organization and might also hit the issues that you're having with certain provider groups, lack of access, which might be physical access, or one provider that's traveling between 3 offices to help with the geography of your health system. And this is another way to kind of patch in there to a specific group. The other use case that is oftentimes touted is post-operative visits that are video visits, usually the second visit, not the first, where a knee replacement, for example, you could actually see how a patient is actually walking around, see by use of a video connection what the wound looks like, and make sure that it's continuing to heal well. And because of global charges with regards to surgical procedures, you don't longer have to worry about reimbursement because you're already getting a global payment. So it's a couple of ideas and reasons to think why you shouldn't try to exclude necessarily one group, but also think outside the box at the opportunities that exist within your organization. I want to thank everybody for joining us today, and hopefully we've challenged you with a few questions or ideas, and I'd love to talk about them further if that's your opportunity. Thanks again.